Well, good morning, everybody. We're going to go ahead and get started. For those of you who don't know me, my name is Eric Isselbacher, and I'm the director of the MGH Healthcare Transformation Lab. And I'd like to welcome you to the Novelline Innovation Speaker Series, which is a quarterly series of talks hosted by the lab that are intended to bring together providers, researchers, and administrators from across MGH to come and learn firsthand from the experiences and lessons of leaders in industry and academia. I'm especially pleased this morning to introduce Dr. Punam Keller from the Tuck School of Business at Dartmouth College. Dr. Keller received a BA in Economics and Statistics, as well as an MBA in Marketing from Bombay University in India. She then went on to receive a PhD in Marketing from Northwestern University. Subsequently, she served on the faculties of such obscure universities as NYU, Columbia, Stanford, and Duke, before finding her way to New England and landing as a professor at Tuck in 1998. Since 2002, she's been the Charles Henry Jones Third Century Professor of Management at Tuck, and she's now also the Associate Dean for Innovation and Growth at Tuck. Dr. Keller teaches health administrators to use strategic marketing to improve the effectiveness of their service delivery systems, and she leads a variety of social marketing projects to increase patient compliance and reduce healthcare costs. Her work has highlighted the fact that people often don't make the choices that are in their own best interest. And to address this, she focuses on how we present information, how we frame the choices, and designing systems that make it easier for people to make the right choices. So this morning she'll be speaking to us about social marketing and health outcomes. So please join me in welcoming Dr. Punam Keller.
Thank you so much. So you can see, I'm over here because I've been told that because of filming and they're very, very clever here, I have to say this, I'm going to give credit to the Innovation Lab, that there's no remote clicker. So I'm an unbridled presenter who is now stuck here. And so I'm just, will you do me a favor? If I start moving in this direction, will you just kind of go? I'll get back over here. So thank you again. I would do anything for this hospital. I can't start like this. You can cut and edit any part of the tape you want, right? Oh, excellent. I spent a month here. You saved my daughter's life. Thank you. Oof. And even coming in here, I was like, oh my God, I'm getting the shh. So I have extra motivation to not bomb this presentation because I'm trying to develop some positive associations. So the next time I come here, I just think, wow, that was such a great, discussion, debate, interaction that we had during this session. And I just, put that massive gratitude in the back of my head and put this in the front. So that's my goal today, so you should know what the goal is. You'll see, social marketing is nothing but what is your goal? Your goal as the end user, as the audience member, as the consumer, as we're gonna call it, or the patient, or the physician, or the legislator, whoever the target audience is, and what gets in the way. So I told you my goal today, yes? You got my goal. So what's gonna get in the way of my meeting this goal? So the first thing that's gonna get in the way is if I kind of go in that direction, I've already told you one problem, one barrier or challenge I'm gonna face, and I'm gonna forget that they're taping and then they have me do it all over again, very bad. The second thing would be if I'm doing all the talking and we're not having a good discussion. So for me, that would not be a successful presentation. So I'm going to tell you about social marketing, and then I'm going to tell you about a couple of projects, and I have more. But what I wanted to do was be flexible. I'm going to ask you, I'm going to show you a couple of those and say, which one do you want to hear about? And if you want to hear about both, that's fine. And then if you want to hear more, we can do that too. But if we're having a good discussion, we'll just talk about one. So this is the other thing you should learn about marketers. Marketers are customer focused, they're audience focused. It's always outside in, it's not inside out. So it's not about I want to do this, this is my goal, I'm going to feel like I'm unsuccessful or I've failed if I don't go through my 50 slides. You've been there, right? No, it's about how you feel as you walk out of here. Whether you think this was worth your time to come in. That, for me, would be success. So, we're good? You already learned something about social marketing. What is your goal? What gets in the way? And what social marketers do is overcome barriers. So let's talk about this a little bit. Let me just also start by saying, thank you, Eric, for inviting me. I think it's wonderful. I was privileged to facilitate discovery in a class that Eric was part of. It's my favorite thing to teach at the Tuck School of Business because, as you'll see in a moment, I can use the exact same slide in the class, and he's going to recognize some, so I apologize in advance, in a presentation like this, as well as in my research. How lucky am I? It's seamless, no walls between what I do, and of course it helps me leverage everything. So I do have a new job since I saw you last, and that's the Associate Dean for Innovation and Growth. And I said, how exciting. Look, here you guys know about innovation. You're part of this innovation lab. And I'll start off by telling you that I made up my title and my position. I figured, you have to sort of provide some evidence that you can innovate. So the first thing you should do is make up your position. And it's been fascinating because unlike health, I have to say, and most of you have gone through multiple education systems, education is not always the most innovative system on earth. So it's an uphill battle, but it's exciting, and I'm hoping I can share some of my ideas with you and that you will inspire me to go back and change that education system by sharing some of your ideas with me. Okay, let's see if I can do this. Oh, yeah, sorry. I actually only have one suit. And I forgot to wear it today, so sorry, but I'm kind of red. But there is that, but we don't need to go over that again. But let's start off with this one, and that is most people, and Eric reminded me of this today, that when I was first introduced to the class and they said it was a marketing professor, they're like, whoa, oh no, and you have all kinds of associations to marketing. And I want to say that I understand that because as consumers, you are faced or bombarded with a lot of marketing stuff that is very unpleasant. Probably just on your way in today, you got bombarded. If you're watching Morning Joe, you're watching, let's not talk about the debate, but all the advertising in between, or you're on the train and you're seeing ads, and you're walking down and you're seeing ads, and even if you could get away from it, once in a while it just pops into your head and you can't escape it. But people have a very negative reaction to marketing, and I want to start off with actually a definition from the Center for Disease Control. I have partnered with them for, now over a decade. And one of the things that I will talk about, so this is going to be interesting. I forget all this, but one of the things I'm very, very proud of right here is my work with CDC that's called MessageWorks. So if you just go on MessageWorks, what it basically does is it allows service providers and health researchers to identify features of the communication that would be most effective for different target audiences. So for example, if you have a communication already and you're trying to figure out who would this work for, so the idea is one size doesn't fit all. Is it going to be better for this audience than this audience? It actually gives you a score and tells you, out of 100, this one gets 60, this one gets 80. You should expect better compliance from the second audience than the first audience. Or if you have multiple communications and one audience, it does the same thing. It will give the messages scores and say, this message is more effective than this message for that target audience. So if you punch in, it's an algorithm, if you punch in target audience characteristics, and there's lots of tutorials, sorry, just ignore all my videos on the website, but there are lots of tutorials to help you code your messages. It will actually help you match the best message for the best target audience. So lots and lots of people, lots and lots of different countries, very, very proud of it. This is the only thing I want to do, really, really focus on. I'll tell you about some of the other work I'm doing, but MessageWorks is great. So I'm a big, big fan of CDC, and no surprise that I often use their definition of marketing to inform my own research. So it creates, communicates, and delivers health information and health interventions using, and this is the outside-in perspective, consumer-centered and science-based strategies to protect and promote the health of diverse populations. So today I'm going to talk about two studies. I'm going to talk about one for a health failure patient population and another one for preventing HIV/AIDS in a larger population in multiple parts of Africa. But I will talk about both those if we have time. So most people, remember, I'm trying to anticipate your barriers. So it's like, okay, how is this different from health education? And communication is education. What is this health marketing thing? So I want to discuss a couple of things. So now see, I'm like being Eddie Murphy here. Remember in Coming to America, like Eddie Murphy puts on many hats? So I'm doing the same thing because I'm an educator and a social marketer. So I'm going to be dissing both, yes? You know how he just sort of makes fun of everybody else because he's sort of making fun of himself. So I hope it's okay with you guys. So here's the education mindset. I walk in here and I say, I know this is a good idea. Let me tell you why this is a good idea. And once you appreciate its good features, you will act in your best interest. Right? You've all been students, and you still are. I hope so. Otherwise, I'm in trouble. I just met the CEO of an airline company. And fortunately, I didn't have to take a plane here, but I was in the UK last week. And I said, oh, I'm going to the UK, I'm flying your airline. And he said, hope it works out. I'm like, whoa! Okay. And then I came back on Saturday and I was having dinner with the surgeon and his wife were going to concert. And he goes, I said, how's it going? And he said, I'm trying to reinvent my life. I'm like, oh, so this is what's so interesting is I feel very privileged, very entitled that I love what I do. And I want to be a student forever. And I want to keep doing this. And I have to tell you guys there who are saving lives that it's very important you feel the same way. Whew. All that drama is only good for TV. I don't want to see it. Here's what a social marketer is, which is just from the get-go. From the very get-go, before you even start the conversation. Here, so we're having a conversation, okay? I always start the conversation thinking, without saying anything to you, you're probably not going to think that what I'm going to say is a good idea. This is how you have to start. This may not be a good idea. Because when you go in with that mindset, you actually begin to listen. Like, what do you think of this idea? Instead of trying to convince everyone, I got an agenda, I gotta go. No. You start with just, it's a proposal. Call everything a pilot. Pilots are great. It's an experiment. Because experiment means you're willing to fail. Right? I mean, it's critical. It's an experiment. It's a pilot. I have this thought. It's half-baked. What do you think of this idea? This is how you always want to start. And this part here are insights on, okay, there are aspects of this idea you don't like. Tell me how to overcome these barriers by how you or someone like you, right? What would it take to adopt this idea? Well, how would we convince someone like you that this is a good idea? Those are the most critical insights any of us as social marketers ever get from anyone, which is how do you overcome barriers? And then we design everything, not just the communication. You'll see communication, delivery systems. Sometimes, even though we don't price things always, as you know, there's a huge cost associated with everything, right? There's social cost, there's all kinds of risks. There's financial risk, there could be health risk. Oh, forgot about that one. And so obviously there's costs associated with it. You have to give up something you really love. So how do we convince people to actually adopt the behavior? So this is basically in essence, the philosophy or mindset of what I'm talking about is this approach instead of that approach. Outside in, inside out, okay? And as I said, I'm both an educator and a social marketer, so let's see if this stuff works. Okay, so tale of two studies. You tell me which one you like and we can talk about it. One is a 30-day heart failure readmission rate. You know, CMS is a little concerned about this because of the first bar on your left there. It's a pretty high number. And I'm sure MGH is doing better. Anyone know MGH's numbers for 30-day heart failure readmissions?
21%.
21. Okay, so not bad. I mean, better than 30, right? Oh. See, you're supposed to tell me. This is audience participation. Okay, sorry about that. That's better, but you've got, that's the national average. You're at about 21%, right? This study was done at the Mayo Clinic in Florida, so you can see what our matched control was. And now you see the intervention. It's pretty good. If I told you that it costs less than $200, it's even better, right? Okay, we're good. So again, it's not even, my goal here is not to convince you to just do the same thing for heart failure patients, which would be awesome, but really to embrace the mindset, embrace the philosophy, and you can use this. If you've got a computer and a couple of $100, you can use it anywhere. So the whole point is you don't need me. Very simple. If you have the right mindset and you can empathize, you can do, anybody can do this. This other study here, oh gosh, I have better numbers here. So I have more recent numbers and we're way over 1 million. Is for voluntary medical male circumcision. And again, both approaches use social marketing. In one case, we don't have to create demand, right? We're trying to reduce demand. In the other case, we're trying to increase demand for VMMC. Okay? And our job here, and it's in different parts of Southern Africa, our job here is to create demand for this as an organization. I'll tell you a little bit about Population Services International. And as soon as we've created a market for it, we back out and let other people come and provide the service. But our job is just to create demand for health services where people don't believe it's necessary as prevention. So in this case, of course, we are preventing them from coming into the hospital even though they are already, we can't prevent the disease itself. In this case, we're actually trying to prevent the disease. Yeah, we're good? Should we talk about the studies? Are you interested? Okay, excellent. So what I'll do is very quickly now tell you about this particular study. We started off with an online survey of heart failure patients to inform us about what their goals were and what some of the barriers were that prevented them from complying with the doctor's recommendations, with the surgeon's recommendations, or the heart failure education team's recommendations. And then we actually went ahead and did this study at the Mayo Clinic. So let's take a look. Okay, so first things, most of you know here that there are 3 things heart failure patients are supposed to do in order to remain at home, remain healthy at home, right? You're supposed to take your meds, you're supposed to limit your fluids, and you're supposed to weigh yourself every day, just to begin with. And I know, it can get more complicated. But if you do those 3 things, especially weighing yourself every day with the idea being that, if you gain a huge amount, like, 4 pounds or something plus in a day, it means that you're retaining fluid and maybe, you need to worry about whether your heart is functioning well. So if you ask the physicians, the health service providers, what is the number one reason why patients are returning, heart failure patients are returning to the hospital? They typically will tell you it's because they're not taking their meds. But I do all this work with CVS Caremark. I've had a 5-year plus partnership with them. And so I can look at the claims data and I can see, okay, I don't know if they're actually taking the meds, but it seems like, they're on schedule. So something is going on here that we have to add to the not taking the meds story. So what I want to talk to you about is a couple of things. which is, are they like thinking, yeah, I know I need to take my meds, but if I don't take my meds, it's okay. Or I know I'm supposed to weigh myself, yeah, but if I don't weigh myself, it's okay. What's the big deal? Do they not understand the consequences of their actions in general? Or is it something more specific? So the two things I should have said this better. The two things I want to focus on here is, one, is it that they know what they're supposed to do, but they don't understand the consequences of what will happen if they don't do it? Or they know what they're supposed to do and they understand the consequences, but they still can't do it. Okay, so those are the two scenarios I want to address. So the first one is the first scenario, don't understand the consequences of their action. So, okay, make sure that they understand what will happen if they don't do these things. And you're saying, wait a minute, we tell them this. I'm with you. In fact, you tell several of them every 30 days. That's the problem. You tell 30% of them every 30 days. This is what's going to happen, right? And this is the second thing, which is actually have difficulty following the recommendation. So those were the two approaches. Okay, so first thing we do is we test these magnets, right? Which is, those are the three things you're supposed to do. There's the hospital, there's your home. And what we're trying to do is, you can see very simply here, there's a gain frame, like if you weigh yourself every day and you limit your fluid intake, you take your medication, basically, yes, you can go from the hospital to the home. Very simple, right? I know these aren't weighted equally, and if I had technology, if I was part of the lab, you could make this much more sophisticated, right? You could even have people online clicking their compliance every time they did something, and you could show this happy person, even themselves, staying at home, comfy couch, etc., versus this one, right? Where if you don't do it, you're going to go to the hospital. And then this one is this mixed frame that if no, you're going in, because, did I do that right? Yeah. I flipped the scale, right? Because that goes 3, 2, 1, 0. This goes 0, 1, 2, 3. So this is a natural progression where, if you don't do this, +1, and you don't do this, +1, and you don't do all three, you're back in the hospital. Okay. We're just curious, what's going to happen here? Which one do you think is the best? You vote. 1, 2, or 3. How many people want to say 1? I'm crowdsourcing. How many want to say 2? Okay, we have a few hands. And 3. Okay, several of you didn't vote. Yeah, this is not a good precursor to what's going to happen here. And that actually was the largest number in this room was that. So we say, okay, that's a good math. Now we understand, yes, they want the positive gain frame. So we'll take a look at this. Yes, that's the one that's going to work. And then we actually get some measures on how they feel about the magnet. Okay, so that's good. So we have why it works, process, action is better than inaction, right? Not doing something versus doing something, and a gain frame is better than a loss frame. Okay, now this is the part that I'm excited about, which is the other part was okay, I understand the consequences, and let's face it, most of these patients, from what I understand, a heart failure is almost like internal waterboarding. I mean, it's not like they like what happens. It's really scary. It's really horrible. So, okay, now they're understanding their consequences. Let's talk about difficulty of following the recommendation. Okay, so I'm going to ask you to picture this study, and then we'll show you the results. 3 cards. So, by the way, the magnets are included in the $200 I was talking about. Okay, so now you got 3 cards. This part is really cheap. So, Eric's my patient. Okay, for once we're flipping. Eric. So I say, Eric, I'm the heart failure educator, okay? I'm part of the team. And he's leaving the hospital. And after treatment. And I say, Eric, I'm so glad that you're going home. I'm so glad you're feeling better. I know that you're aware of what you need to do after you return. And I have the 3 cards and I put them in front of him, just like that. And I say, some of our patients have told us that even though they know what they're supposed to do and they know what will happen if they don't follow these recommendations, they have some challenges. And I'm going to give you an example of a challenge for each of these. So for example, weigh yourself daily, right? was doing this presentation at a very, very large hospital in New York. And I had the chief medical officer actually sitting in the front row, and he said, okay, what is the big challenge for weighing yourself daily? And I typically ask people, okay, you tell me, why don't you weigh yourself daily? And it's normally psychological, like I don't want to know my weight, blah, blah, blah. But for some of these patients, as you know, it can be a much bigger barrier, right? So he said, of course, everybody can weigh themselves. And I said, well, come up here, sit down, little stretch, sit. And I said, here, imagine here's a scale. Now get up and weigh yourself. And so he got up, and I said, you're wheelchair bound, you can't get up. Outside in, not inside out. So what we often do is we will go and study patients in context. Behavior change takes place in context. You have to understand the person's reality to understand the barriers that they're going to face, the compliance barriers, to actually follow your recommendations. Now what do you do? What if you can't get up? My favorite is they say, oh, what a cane, you can do it with a cane. I have now adopted the cane as my new weight loss strategy. It's a great strategy to lose weight. It's very good. Yeah, we're talking about a few pounds here and there that can render the patient, right, unconscious. It's ridiculous. So what are we doing? And it makes me excited to be part of this group, because now, of course, we can think about all kinds of things we can do for our heart failure patients who have comorbidities such as diabetes or compromised eyesight and not being able to see the scale, right? And being able to automatically get a weight, a daily weight, right, that is registered with their heart failure team. But I can't tell you how difficult this was. So I'm back to Eric, and I'm giving him an example for each one. Limit fluids. I say, Eric, some of our patients say that actually some of the medication gives them dry mouth. Even just taking all the medications renders them over the fluid limit. Or that they didn't realize how much liquid there is in prepared foods. Or they thought water was okay, that it's other kinds of, and so on and so forth. And of course, where am I getting these barriers? It's because I'm talking to patients and I'm asking them from a social marketing perspective, what gets in the way? I know you know what you're supposed to do. What gets in the way, right? And so I tell Eric another one, and then I say, Eric, I know you're supposed to take your meds, but our patients tell us, here's what might get in the way of taking their meds. And then I say, Eric, is there anything that might get in your way of following these recommendations? And Eric says, that one. And then as the heart failure education team person, I flip it around. You see? I flip it around, and you see, this is, sorry. Well, we can leave it there. I flip it around, and I write down his name. There's a name thing, and there are a few lines in there that says, challenge, solution, just to start him off. And then I'm going to give him long sheets for other challenges and solutions, a more comprehensive list. But I wanted him to have something right there and then. And I'm just going to hand that over to him and put that in his folder that he takes home. Okay, so wanted to give you an example first of not making assumptions. So if you look at the three, as I told you, medication adherence is the thing most physicians say is the biggest challenge, and look at what we're finding. Yes? So good not to make assumptions, right? Good to ask people what gets in your way. Now I can go really fast because you know what I did, right? So this is what Eric is telling me, right? And this is the data that we're getting. This is the one I was looking for. Now you see the flip side, yes? I'm going to put all these sheets in his folder. Yes? And of course, I'm working with the health service providers to get these lists. Because of course, I'm not going to go ahead and make all kinds of recommendations on my own. So we then start testing things. How likely do you think you will need the emergency room in the next 30 days? And we ask about the cards, and we ask about the magnets. And we have, oh, this is not good at all. I had white and then I changed it. So, I can briefly tell you that this slide covers what we did in the Mayo Clinic study. So you know what the goal was? To reduce 30-day heart failure readmission rates. The participants are obviously 30 heart failure patients themselves. Measures, we're going to ask the patients about their ability to stick to the recommendations. The methodology is we train the heart failure education team. They have the conversation with the heart failure patient, just like I did with Eric, and then we measure 30 days and 60 days out, et cetera, whether they're back in the hospital or not. Yes? And then, of course, we also talk to the heart failure education team to find out how they feel about the intervention, because they're the ones who are providing the intervention. So we have the barrier cards, the FAQ sheets, and the magnet. Right? So those are the three things. You already know this, this is how it goes, this is so lovely, which is the first thing that was so excellent, in addition to the results, of course, for the heart failure 30-day readmission rates, is how happy the heart failure team felt about the study. They felt that the barrier cards were an education aid, that they were giving their patients more than they did before. These are the ones that were significant. So we asked, compared to before, did you feel like, this was a better intervention? They were more engaged with the patients and that they empowered the patients more than before. Sounds pretty good? I mean, that's what I would want. If you told me as an instructor, as an educator, would you be happy if you empowered your students more, et cetera? This is exactly the outcome I would be looking for. You already know some of the results, and there you have it. Okay. So I just want to pause here for a moment to, the second study is basically the same idea. And I can show it to you really quickly in like less than 5 minutes if you like, the voluntary medical male circumcision. But the idea of it is basically, that don't focus on the benefits of compliance. That's what we typically do, especially for a recurring problem. They know the benefits of compliance. They're back there not because they want to come back to the hospital. Well, some do, but let's not talk about that population, right? Let's not talk about the benefits of compliance. Let's think about compliance barriers. It's much more important to think about compliance barriers and overcome barriers than to think about the benefits of compliance. In order to identify and overcome compliance barriers, you absolutely have to understand the patient in context. So once you start looking at the patient in context, you can start tailoring your recommendations for what they need to do to actually overcome barriers. Now I know some of you are saying, oh my God, you have no idea how busy I am, and I am a gerbil on a treadmill, and I have 5 minutes with a patient and talk to admin, you're preaching to the choir. I've been doing this for a while. No, okay, I understand. The point is, if you believe that this is useful, or to give it a shot, the pilot, do an experiment. Who can get this information from the patient? As I told you, heart failure education team spend less than 7 minutes on average with the patient as they were exiting. As you can imagine, they want to get the hell out of there. And they're not always in the best state. And sometimes we're really having a conversation with the person who's helping the patient. Or the aide. So think about this, okay? Who should be doing it? Is it a health coach? Is it an education team? Can this be part of an hospital exit strategy? Okay. Include caregivers in the conversation. Very simple, very effective. They don't have to use technology, but hey, if you can, look, can you guys here come up with, that's what I love about identifying barriers. You can come up with great ideas for running studies, right? Now, for example, can you modify a tire pressure gauge so that my wheelchair-bound patient can get an accurate weight every day? I'm just throwing it out there. I'm no engineer. But I'm figuring, okay, there's some air thing going on. Could we adjust it? Could we modify this? Could you figure this out? And see what it does is because you're solving problems, right? You're trying to figure out problems, just like you do in the lab. In the innovation lab, I've been talking to people before the talk started to find out, well, what do you do? Give me examples of studies. And I think this would be a very good approach to say, oh yeah, okay, you know what? Overcoming compliance barriers might be a really good way of designing tools. Okay, so this is gonna be supercharged fast. Watch me, okay? I'm going to be like Kane on steroids. Same idea, right? Identify the barriers. So yes, World Health Organization and the United Nations Program on HIV/AIDS has blessed male circumcision, medical male circumcision, as an effective way of reducing the acquisition and dissemination of the HIV/AIDS virus. So once they bless it, we're off and running. So a study is done. I'm on the board of Population Services International that provides over-the-counter health products and services to the most poorest isolated people on earth. So we go to exciting places. My last trip was Niger and Democratic Republic of Congo. But most of that's up there, but most of the studies that I'm talking about are actually here in Southern Africa. So, ready? Barrier solution. Access barriers, mobile outreach. Cost barriers, remember, cost is not just price, but other costs, right? So transportation. Stigma, very important, right? So this particular thing was in Zimbabwe. A third of the population is infected with the virus. It's horrible, so over 30%. And what you're seeing here is actually a young and revered singers who developed a song about HIV/AIDS and how it affects different countries in Africa. So the idea was, it's not just you, it's us. So that was very important, overcome stigma. The whole idea that if you lose your masculinity if you are circumcised. Yes? Okay. Pain. So we have pain ambassadors. Oh, this was one of my favorites, very interesting. A lot of the times, actually, it was the women in the relationship that were preventing the males from getting circumcised. I was like, why wouldn't you want to be safer, right? I mean, it just was, if you just don't think about it in context. But if once you start thinking about it in context, you find out, it's because they actually think that they would give their men license to cheat if they were circumcised, right? Now they're safe, they feel like, I have a smaller chance of acquiring the virus, or maybe even they care about disseminating the virus, I'll get circumcised. What's wrong with that, right? And so what we started doing is focusing on health and fun rather than on HIV and AIDS. So we had this commercial, the two women, they're talking to each other, and one is married and one is not, and the one who's not married is checking out the guys who are walking to the bar, and she said, oh, he looks cute, and the other one says, do you think he's circumcised? So, well, why are you asking? And the married woman is saying, oh, ever since my husband got circumcised, it is just so much more fun, and it's much, okay, I won't go into the details, but especially not in, the language makes it sound even funnier, but the idea of it just being that it's more hygienic and it's more fun. And that was very important, overcoming all. Oh, then this is the strong poaching on the weak, that you're doing this, a little bit of not that anybody in the United States has heard about a conspiracy theory, but there's some going on in different parts of Southern Africa as well. And the idea here was that, they're just trying to circumcise us so that we limit our population, and that's what they thought it was for, and then, they'll be more than us, and they're trying to keep it's a population control mechanism, etc. So we actually had several very senior ministers get circumcised publicly, not in public, but say they were going to get circumcised, walk in, and then do interviews afterwards in Zimbabwe. So you're just seeing, different ways of overcoming barriers, right? We find out what the barriers are, we overcome barriers, and as I said earlier, we are so you can see in 2015, we are way over 1 million here. And then we do other projects. Right now we're doing a population control project in Niger, bottom of the Human Development Index, in part because the average mother has over 7.3 kids per mother, and 4 mothers per household. You do the math. Pretty bad. So, I went down. Just leave that up there for inspiration and take any questions that you might have. I figured, this is an innovation series. It's the least I can do. Deepak Chopra, I'm a big fan, says we suffer almost anything in order not to change. Yeah. So from an individual perspective, as well as thinking about innovation in general, it's not easy. I know what I've said is a little out of the box, but what I'd love to do is spend the rest of the time today discussing, how could you use this kind of approach and what might get in the way? Yes? Okay, let's go for it. I know, sorry. It's gonna be even harder for me than before because now I'm not tethered to this. I know, Robert Frost, I'm always telling myself, freedom is being easy in the harness. Okay, I'm gonna try. Isn't that nice? He's a smart man. Yes.
This was absolutely fantastic.
Thank you.
And I think we are all going to walk out of here inspired. And then sometimes something happens after we're inspired. We have an idea, we have a pilot, maybe we have a successful pilot. And then to go from that to implementation at a larger level, even a larger level, a mini version of a larger level, seems like everybody is doing the Deepak Chopra, I'd rather not change around you. How does one overcome that? It's almost behavioral change in our colleagues. How do the early adopters in this room get everybody else to get on board with these ideas?
Such a great question, right? So I forgot to tell you, so at Mayo, of course, now, I shouldn't say of course, I'm very fortunate that it's a quality improvement project, yes? And the goal, of course, was why, if we can get these results as, over time, and a much larger sample, et cetera, then can we use the approach for other things? That's of course, a researcher's dream. I'm hoping it's also the health service provider's dream. Because it, so the thing I think, a couple of things get in the way. That's a great question. What gets in the way? How do you overcome the barrier? So one barrier is that other people around you don't have any ownership of it. They don't feel like it's their project. So the more you can involve the people that you know whose buy-in you're going to need early on, the better, right? So even if you have to pretend, you edit that part too, okay? Even if you have to pretend, say, hey, can I bounce this off you? Can I just tell you about this thing? I may be going about this way and it may be hard for you to see how useful it is. Can you give me that outside in perspective early in the project? So that's the first thing that I always try to do. Including when I'm trying to do things, I have to involve faculty and trustees and the college itself, because I know if I can get buy-in early, that's going to be easier for me, and they become my apostles, right, instead of the terrorists. The second thing I think is really important is people often assume that the costs are going to be really high. So the more you can write down in very simple ways what the process is, that's why I like visualizing, just talking about even before showing you all the boxes and the methodology, just talking about it very simply so that they can see it. Most people automatically assume the status quo is easier than what you're about to propose, that the process is going to be really complicated, it's going to disrupt the whole system. God knows we don't want to do anything to mess up the operations of anything in the hospital, right, or the medical institution in general, because it has this domino effect, right? You do this and so they're scared. So they like your idea, but they don't understand what the costs are. Another one is the actual cost. They think it's going to be hugely expensive, and what you're really doing is saying, I'm going to have to throw all this, and so you've got to start saying, look, in fact, how I would start? I would say, before I even tell you about my idea, I know other people have come to you with ideas in the past, and it hasn't gone anywhere. What prevented that idea from going further, even though you thought it was a great idea? Get a list of their barriers. And then start systematically overcoming those barriers. I just gave you a few. As in, not invented here, the process, it's going to be too difficult, it's going to be too expensive, right? And who knows what else? I don't have the time, right? I can't take this risk. Sometimes you have to ask 5 whys for people to actually tell you the truth, right? It's difficult. And then maybe they're just scared. So say, look, we'll own it. It's an experiment. We'll pilot it. Tell them, attach it to a goal they have. There's an innovation award. Don't you guys have innovation awards? You should. Right? And the idea that, oh, you know what, this is going to make you look good, right? Because that's the whole idea is, okay. Or ask them the same thing. What is your goal? Is your goal to have the best department, the happiest service provider team? What is your goal? Oh, you know what? We have some data that shows that, this will make your heart failure education team really happy, right? So approach it from their goal instead of your goal. Because I know a lot of medical providers, if you tell them this is going to reduce the cost, they just roll their eyes and say, oh, you too. But if you tell them that this is going to make your patients feel better, if you tell them that this is going to, reduce the number of patients who come back to the hospital, then it's so much better. So I feel very much like a parent where, same thing for you guys, where you're responsible for the patients, but you can't control their behavior. And what happens before they come to the hospital and what happens after they come to the hospital is you're responsible. Even your reimbursement is a function of it, but you can't control it. So what I'm trying to do here is have that outside-in perspective to give you an opportunity to address some of that stuff while they're with you, in a sort of empathy, empowering way. Not judging, not saying, why is this a problem, or don't be ridiculous, of course you can stand on a scale, or what do you mean you don't know how much 6 ounces is, etc. But in a kind, gentler way to say, I can see why this would be a problem, and let's discuss how you can overcome this, because unlike other people, this could have some really serious consequences for you, not for us, for you, and hopefully that will go somewhere. So. But happy to discuss some more, but that was a really good question. Other questions? Ways in which you could use it. I'll print the cards for you. Really simple. And now they do batch jobs, so I have hundreds of cards. If you want mine, I can give you mine. I have a lot more. Other thoughts, other ideas? Yes?
Dr. Keller, thank you. Great presentation. I'm just wondering, in your research, if you were able to identify, so back to the magnets, using positive,
Right.
You got points for doing these things. How long did it take for patients to actually complete that and maintain it?
Right. And so, we're looking at 30-day, 60-day, 90-day readmission rates as well. And so it's interesting. They didn't have to do anything, right? So all they do is stick the magnet on their fridge. And we put it on, we used a magnet instead of something else because we figured 2 out of those 3 things were related to fluids, and we thought, let's put it someplace where it would be accessible to them. The reminder would be accessible to them. And it's a really simple thing. As I said, obviously, taking your meds should have a much larger weight than drinking fluids, But we were just making it really simple because we tried different things, and just like a Weight Watcher point system, We're just saying, yeah, this is good. This is good for me. I just need to be careful about this. And not make it too complicated. So it was really more of a reminder than anything else. And then we basically asked them, did this help you? Remember to drink less water or to weigh yourself, etc. And we also try to make it simpler where, we said move your scale, to the bathroom, or move your scale to the kitchen, because, again, making it more accessible and bringing it closer. So I'm a behavior change person, I'm a behavioral economist and a psychologist. I'm constantly trying to figure out, what are the nudges that we can use to help people be more compliant or overcome their compliance barriers. Any other questions or thoughts? I know we have a few minutes left, but make my day. Oh, thank you.
Thank you. I am wondering what you would say when the barrier is emotional, when it's fear, not I can't get out of this.
Love that. And and also first, kudos to you for being in a position to get someone to trust you to be able to even share that. Right? I mean, it's not easy for people to share things like that, so you must be fantastic. To get someone to tell you the truth, because of course that is a massive barrier. And we have all kinds of interesting ways to overcome negative emotions, which we know can basically freeze and seize all behavior, where you just basically freeze in response to emotion, and then that's it. You're not receptive to anything after that. So I really appreciate the question. And so happy to have a longer discussion about this, but just like a therapist or a psychiatrist would help you overcome fear, right? So the question is, well, you go back to the same thing. Well, what makes you scared? What do you think is going to happen, right? We often do this very instinctively as health providers with pain, where we come up, pain is a big fear, or I'm going to die is a big fear. And sometimes, I put my little Buddhist hat on and say, I'm dying as we speak. I am. By the way, you are too. And dying, I'm doing an end of life project. Dying is basically, actually, when you say I'm dying, most people just think of it as the few minutes, or maybe even for you guys, maybe a longer time period before you actually die, right? It's the event before death. But I'm deteriorating as we speak. And it's not as scary a process when you realize, I'm just preparing myself to die. And it's amazing because it happens so naturally. I don't even have to do much about it. I can hasten the process by eating all those croissants outside, but we are actually all dying. And there's all kinds of different ways of thinking about it, but the idea being that it's not something to be terrified of. It's something that everybody is going through. You're not the bad one, or you're not the one that was singled out in any way. You show me someone who's not dying, and I'll we can have a really good conversation. They're the ones, right, who should be extremely scared. We're the ones, it's just a very natural process. And we can talk about lots of different things, but often I'm giving you a off the hip answer, but I often, when it's something related to fear, I have to have a longer conversation to find out what the source of that fear is before just doing this. But if it's fear of dying, that's the normal trajectory that I go on, which is I tell my story. And by the way, fantastic book. It's called The Book on Living and Dying, and it's by a Buddhist monk. And I'm constantly looking at different things to help inform me about, how different people from different religions and different backgrounds may be thinking about health and especially dying. And I have all kinds of different tools. So the End of Life project that I would love to work on, so I'm going to make a quick pitch, is how to get more people, not patients, people, us, to fill out advance directives. And so I often, I find out, well, what is the barrier? And the typical barrier is, guess what? They don't want to do it. Why? Why? And it's because they actually think that it means they're going to die. It's acknowledging that they're going to die. And so I say, okay, so how about we give you a forced choice, right? In palliative care or in some other medium or other context, and we say, I want to decide how I will die. I want the attending physician to decide how I will die. But those are the choices. Die you win. Because really the third choice they want me to give them, or I want my family to decide how I will die. But you can't say none of the above. Like, what does that mean, none of the above? Nobody is going to decide how you're going to die. Are you going to die homeless? Nobody will know. But basically, you've decided how you're going to die, right? So it's a very much an accountability 101. Be responsible for yourself, but also an acknowledgement that you're not in this alone. We all have to do this, and we're all going to die. And we all have the exact same choices. Nothing special about you. And it's amazing how quickly people just go, okay. Yeah. As in, I have a very cognitive approach, a very fear or less emotional approach, but definitely emotions can make a big play. I just want to thank everyone for coming. Easy to find me, easy to find everybody now. Now that's something you should be fearful of. And I hope that you'll be in touch either with examples or with questions, or if you like some free consult or feedback on some of the things you're doing, I'd be very, very happy to participate. Thank you so much.